cardiac autonomic dysfunction is a malfunction of the autonomic nervous system. It's a type of neuropathy affecting the nerves that carry information from the brain and the spinal cord to the various visceral organs. Diagnosis is achieved through functional testing of the autonomic system, focusing on the affected organ. Inherited or degenerative neurological disorders cause autonomia, which is called primary. Then we have secondary, like diabetes or some, kind of traumatic. Then side effects of drugs, we call it iatrogenic dysautonomia. The signs and symptoms will depend upon the region involved, but most of the time symptoms are either fatigue, polydipsia, lightheadedness associated with orthostatic hypotension, which may result in syncope, tachycardia or bradycardia, blood pressure fluctuation, difficulty in breathing and swelling. So when we talk about the cardiovascular autonomic system branch, it is responsible for the regulation of heart rate, blood pressure, and it maintains homeostasis during physiological stress, including exercise and standing upright. Autonomic nervous system constantly controls the rate and force of the cardiac contractions and the vascular tone with the aim of to maintain sufficient tissue perfusion with oxygenated blood and also secure venous return to the heart. Blood pressure is governed by the peripheral baroreceptor system and cardiovascular center in the medulla oblongata. Cerebral circulation is protected by the high pressure baroreceptor reflex mediated through carotid sinus sensors and the self-adapting system for cerebral autoregulation. So this is in brief. You see there is a central point in the hypothalamus, then you have a center in the medulla oblongata, then you have these three nerves, the glossopharyngeal, vagus nerve afferent and efferent, then you have the cervical chain, sympathetic. So either it is the cardiac dysautonomia or the vascular. When we talk about cardiac, means pump dysfunction, hyperadrenergic ports, inappropriate sinus tachycardia, reduced heart rate variability, chronotropic insufficiency, cardio-inhibitory vasovagal syncope and cardio-inhibitory carotid sinus syncope. When we talk about vascular, then we are talking about pipeline dysfunction, arterial hypertension, orthostatic hypertension, abnormal blood pressure variability, neuropathic, hypovolemic ports, orthostatic hypotension, postural hypotension, vasodepressor, vasovagal syncope and vasodepressor carotid sinus. The malfunction of the cardiovascular homeostasis is regulated by is known as the cardiac dysautonomia. The process may be paroxysmal or it may be chronic. Failure of the either sympathetic or parasympathetic system can result in unopposed action. The common cardiac manifestation of dysautonomia include either reflex syncope, inappropriate sinus tachycardia, syndromes of orthostatic intolerance, orthostatic hypotension, and postural orthostatic tachycardia syndrome, which call it POT syndrome. So it may be cardiovascular autonomic neuropathy may typically manifest as orthostatic hypotension, reduced heart rate variability, inadequate sinus tachycardia, and exercise intolerance. And similar of these autonomic abnormalities are frequently seen in heart failure patients, and they complicate the management of these patients. Cardiovascular dysautonomia may affect local circulation, leading to cerebral, coronary, and peripheral circulation. That means it may affect certain regional vascular beds. Different types of may coexist, like patients with orthostatic hypotension may have also chronotropic insufficiency, whereas patients with POTS may have inappropriate sinus tachycardia and recurrent vasovagal syncope. Dysautonomia may coexist with primary cardiac disease. Orthostatic hypotension may accompany heart failure, atrial fibrillation, and ischemic heart disease. Being alert to the possibility of cardiac dysautonomia is important when we deal with these patients. So out of these dysautonomia, postural orthostatic tachycardia syndrome is one of the very prominent abnormality. Usually young women are involved. Syndrome consists of orthostatic intolerance for at least 6 months duration, which is defined by increase in the heart rate of more than 30 beats per minute when you stand, or more than 40 if the age is less than 90 within 10 minutes of active standing, or passive tilt testing without a significant drop of systolic blood pressure. Upright Heart rates generally exceed 120 beats per minute, especially in younger people. Symptoms are, quite multiple: dizziness, palpitations, fatigue, headache, nausea, presyncope, tunneling of the vision, and brain fog. A clear exacerbation of symptoms and an increase in heart rate when assuming an upright posture is diagnosed. So that is a clinical situation. This is one of the POTS patient to show that how on head up tilt the heart rate increases in this patient. POTS patient may also have coexisting neurally mediated vasovagal syncope. Those most affected are women between the age of 15 and 35 with a prevalence rate of 0.2%. Underlying mechanism may include catecholamine excess due to either abnormal biosynthesis and release or reduced clearance, peripheral autonomic denervation and autoimmunity against adrenergic and other cardiovascular receptors. Several POTS subtypes have been proposed, like hyperadrenergic, neuropathic, and hypovolemic. During an acute episode, these patients will have an elevated urine methylhistamine. This level will be normal between the episodes. Cardiovascular deconditioning, that is reduced exercise tolerance and diffuse muscle fatigue, are common denominators among the various POTS subtypes. Physical inactivity results in cardiac atrophy and hypovolemia. Early physical activity in the recumbent or horizontal position is recommended. So these people are encouraged to exercise while they are lying recumbent. That helps these patients. So they have also, this is typical rash involving in axillary and lower extremities of a woman with postural POT syndrome. When we talk about hyperadrenergic POT, these patients will have an elevated standing plasma norepinephrine level more than 600 micrograms per ml and account for 30% of all POT patients. During head-up tilt testing, these patients have greater increase in systolic blood pressure and heart rate, and they report more symptoms of headache, tremulousness, and dizziness than other subtypes. And these patients, they respond to beta blockers. When we talk about neuropathic postural, POT, these patients have signs of peripheral autonomic denervation and impaired pseudomotor function with the diminished sweating of the distal lower extremities. These patients have lower heart rates, less anxiety, and less impact on their quality of life than other types of POTS. These patients may have also excessive venous pooling along with the acrocyanosis while assuming upright posture. Use of compression garments to reduce the venous pooling in these patients may be helped. Then we talk about the hypovolemic postural POT. Patients are noted to have low plasma volume, no compensatory increase in plasma renin activity despite the lower circulating volume, along with the low levels of aldosterone. Treatment of these patients should focus on expanding the blood plasma volume and physical reconditioning. So these are various, I don't want to go into the slide, the disorder and the modality of testing, and then interpretation of results. This data is available in the textbooks. I am sure you can go through this. When we talk about another autonomic dystonia, inappropriate sinus tachycardia. This is defined as a resting heart rate more than 100 beats per minute and a mean heart rate of at least 90 beats per minute over a 24-hour holter. A distinguished feature is the lack of exacerbation of symptoms with upright posture. They remain the same. Sinus tachycardia related to other conditions, we obviously like anemia, thyroid abnormalities, we have to rule it out. We did a 12-lead ECG during the episodes of tachycardia to exclude other atrial arrhythmias. A high intrinsic rate, depressed, different cardiovascular reflex, and beta adrenergic hypersensitivity may be seen in these patients. Obviously, you need to do a holter to define 24-hour rate. This is one of the examples of inappropriate sinus tachycardia. The lower one is the inappropriate, the upper one is the POTS patient. Then we come to orthostatic hypotension. It is very common. It's defined as more than 20 millimeter of systolic drop of blood pressure and more than 10 diastolic within 3 minutes of active scanning. In patients with spine hypertension, a reduction of systolic BP of at least 30 millimeters might be considered as important. It is the most common form of cardiovascular dysautonomy in the middle-aged and elderly people. It's a very common problem. Younger it is less, but when we go, more than 70, it is up to 20% of the patients have orthostatic hypotension. Also, to a lot of patients complicated by other cardiovascular drugs, particularly vasodilators. Orthostatic hypotension in physiology involve the insufficient compensatory mechanism acting after assuming a standing position, impaired peripheral vasoconstriction, inadequate chronotropic response, and reduction in the venous return. And this is one of the reasons of syncope in many of these patients. This is what is shown in this slide here. They drop of pressure when they stand. Orthostatic hypertension. Fall in BP while standing may be due to structural or functional sympathetic denervation or impaired baroreflex response. The former is usually denominated as neurogenic orthostatic hypertension, accompanied by blunted chronotropic response on standing and history of neurodegenerative disease. The delayed form is due to a gradual impairment of adaptive mechanism during orthostasis, resulting in a slow progressive drop in arterial pressure of the same magnitude in classical form, but occurring first after 3 minutes. This has been associated with milder impairment of sympathetic function. In terms of syncope incidence, this is second most common. The orthostatic hypotension is the second most common etiology of syncope, occurring in approximately 10 to 15% of syncope representations. It is often unrecognized or even misdiagnosed. The pacemaker implants really don't help in these patients, and I have seen many patients getting pacemakers, but they really don't help the patients. This is what is shown in this slide, again the same physiology. So orthostatic hypotension should be always suspected when syncope or characteristic symptoms occur while standing in a warm environment after large meals, overlap with postprandial hypotension while going to the toilet during night or after awakening and getting up in the morning. Now we go to reflex syncope. Is the result of paroxysmal parasympathetic activation and sympathetic withdrawal, resulting in hypotension and bradycardia. Reflex syncope is generally benign and doesn't lead to significant morbidity and mortality. The possibility of a genetic predisposition related to serotonin signals must be considered in these patients. Two most common forms of reflex syncope are either vasovagal and carotid sinus syncope. So I think these are symptoms very common, so-called aura in many of these patients. You know about this thing. Vasovagal is very, very common form of syncope among all ages. There are two peaks in younger people, then there is again incidence increases after 60, 65 years of age. A trigger may be the cause like emotional distress, pain, fear, blood sight. A prodrome of non-cardiovascular symptoms resulting from activation of the vagus nerve like nausea, sweating, diaphoresis, pallor, yawning, salivation. These are very typical of a vasovagal syncope. Symptoms associated with cerebral hypoperfusion like dizziness, lightheadedness, blurred vision, scotomas before the total loss of consciousness. In terms of hemodynamic response, this is vasovagal may be cardio inhibitory with a lot of bradycardia. It may be predominantly vasodilatory with the dilatation or a mixed response. Carotid sinus syndrome is another reflex phenomenon where people are sensitive and they may have severe bradycardia and syncope. By definition, the pause should be more than 3 seconds. I really don't know what is the value in clinical practice. We have to be very sure before we consider pacemaker in these patients. So there is many other forms of cardiac dysautonomia. I think I can leave because of the lack of time. So if we have a syncope, if we have initial evaluation, history, physical examination, and ECG, these three things, actually the most important thing in syncope is a clear history. That's what we should do a lot of emphasis. If we are clear from the history, then no additional investigations are required. But if we are not clear, we have to targeted blood testing, initial evaluation suggests neurogenic orthostatic hypotension. We should check for autonomic evaluation. If there is initial evaluation suggests reflex syncope, then tilt study may be useful. Of course, the sensitivity and specificity of tilt is not very high, so we have to keep that in mind. If the initial evaluation suggests cardiovascular abnormality, then cardiac monitor or a ELR or a long-term monitoring is needed, like implantable recorder or the external recorder. Some of these patients may also need additionally stress testing, transthoracic echocardiogram, electrophysiological study. I want to tell you that most of the patients with syncope, MRI and CT scan are absolutely useless and wastage of time. And EEGs are done, which again are totally useless in these patients. The thing which you have to understand that syncope is a cardiovascular phenomena, it's not a neurological phenomena. So let me complete by concluding, apart from most prevalent arterial hypertension conditions like postural orthostatic tachycardia syndrome, inappropriate sinus tachycardia, orthostatic hypotension, reflex syncope, they should be known to the cardiologist. It's a very common practice. Thank you very much for your kind attention.